So with that, I'm going to bring on Dr. Greg Leman, Greg Leman with Blueprints Labs, which works with out of Baylor University, is an advisory council leader of ours and a great friend. And he's got a great background, a logo. I think wish I had your background. My computer doesn't support it, but you look sharp, my friend. How are you today?
I'm doing well. Thank you. Thank you.
Great. Well, I know you're going to have a fantastic discussion with Dr. Peter Holtz, who is one of the leading virologists in the world and really, really sought after with regard to the pandemic, COVID, et cetera. And so I'll turn it over to you, sir, and I hope you guys have a great chat. We look forward to following up with you at the end.
Well, thank you. Thank you so much. And as has been said already, this team is such a pleasure to work with. And thank you for this opportunity. I'm going to, I guess Dr. Holtz is joining independent of what I do from his location, but we are very privileged to talk today to one of the leaders who have helped guide this nation through the solution part of how we respond to the pandemic. And I love some of the things that General Levy had to say about how that experience, needs to be applied across the board. But so let me tell you a little bit about Dr. Holtz for those who don't know him. Peter Holtz, MD, PhD, is a professor of pediatrics and molecular virology at Baylor College of Medicine. He also there co-directs the Texas Children's Center for Vaccine Development and holds an endowed chair in tropical pediatrics. He is a vaccine scientist who led the development of vaccines to prevent and treat a number of neglected tropical diseases and coronavirus infections. Right now, a new Texas children's COVID-19 vaccine is being accelerated under his direction in India and is undergoing clinical testing. So many of you have seen him in news outlets in recent days and months. So, Professor Holtz obtained his undergraduate degree from Yale and his MD and PhD from the Weill Cornell Medical College and Rockefeller University. He's authored more than 550 scientific articles indexed on PubMed and is the author of 4 single-author books. He is an elected member of the National Academy of Medicine and American Academy of Arts and Sciences and has been honored by the WHO and WHO Research America, NIBRIF, American Society of Tropical Medicine and Hygiene, as well as a number of other organizations. And as I said, he appears regularly on major news outlets promoting global health and vaccines and immunizations, and finds himself needing to counter anti-vaccine and anti-science movements that are out there. So please welcome Dr. Peter Holtz to our program this afternoon.
Thanks so much for having me.
It's a delight to see you again, sir. You probably get on have a chance to speak where everybody shares some of your scientific background, and we're gonna kind of strain you a little bit today to get you to think and comment not so much about the science of vaccines, but about the whole process of that ending up in the right hands and helping the right people. Because as General Levy said, that supply chain represents a very tested scenario. Crisis is where we learn a lot of things. So I do want the audience though to know more about the work you do, and so let's start with a question a little bit along those lines from the perspective of somebody who is one of the world's foremost healthcare thought leaders. We're wondering what it is in your view that makes COVID-19 so different from previous outbreaks, and also, what do you think are the most critical lessons to date for the COVID-19 response? Both, you're aware of a global response as well as in the U.S. And anything you could share with us on that?
Yeah, no, absolutely. I mean, I think there's some things that are related that are intrinsic to this virus, the SARS coronavirus type 2. And I think there are things that were revealed with deficiencies in terms of our national response and the response globally. So I think in terms of the unique feature of the SARS coronavirus, it was the simple fact that these viruses have the ability to replicate in our upper airway, in our nose and mouth and throat, and in some cases produce no symptoms. So about half the people with COVID-19 have no symptoms and yet are shedding a lot of virus in their nose, mouth, and throat on the one hand. And on the other hand, there's another group of people, especially older individuals or those with underlying conditions such as hypertension or diabetes, or even some with not even obvious risk factors, who get very sick and wind up in the intensive care unit and lose their lives. And that Janus face, that two-faced aspect of the virus, has been what's so problematic. And if you remember with the original SARS virus back in 2002, 2003, came out of South China and affected Toronto. If you had it, you knew it. You were sick. You were in the hospital. You weren't walking around going to bars and restaurants and sporting events. This was so different, and that simple fact has made it so profoundly difficult to control. So I think that's a major point. I think another, when we still don't really entirely understand why things collapse so badly in terms of our public health response to the United States. I mean, we missed the entry of the virus from Southern Europe into New York City. It was around for a month before we realized anybody actually had COVID-19. And that allowed transmission to take off, causing that devastating epidemic in New York City. We never got the diagnostic testing up and running. We never figured out how to do genomic sequencing at scale. So as a result, with the UK variant and the South African variant, we had no idea until it was pretty late in the game that it was here. So we came up small in every way in our federal response. And in lieu of that, what we did was insist the states had to be in the lead. The states had to be in front, and the US was only there to supply backup support. And that was a catastrophic decision because the states never had the epidemiologic horsepower to actually know how to do this stuff. They didn't have the epidemiologic models. They didn't have the knowledge base. I mean, there are times when you actually need the full force of the federal government, and this was one of them. And we did not have the CDC out in front, and we don't really know why. I mean, we haven't really had a thorough dissection of how that got so mangled. And a lot of people want to blame the Trump White House and White House incursions, and no doubt that was a role. But I think there was something even more profound that went on, where our Centers for Disease Control just was not able to organize itself to launch a federal response. And so that'll take maybe months or years to figure out. And then you had the disinformation and this very odd tying of political allegiance to being defiant of masks and social distancing. And we'd never done that before. It came out of this health freedom, medical freedom movement that started around 2015. Unfortunately, where I am based in Texas and Oklahoma. And then in 2020, they glommed down protests against masks and social distancing. And that was also another factor. So yes, this virus would have been a challenge for any administration, but you combine it with the fact that there was never the federal government out in front, and the fact that you had this political defiance. I think those things combined to get us where we are today. Yesterday we marked that milestone of 500,000 Americans losing their lives. We should never have gotten to that point. We should have been able to halt the surge that happened last summer in the southern states. We should have been able to halt or at least delay that fall surge long enough until all the vaccines were here, and that could have cut the number of lives lost by 65, 70%. But still would have been a devastating epidemic, but nothing like we've had before.
Well, certainly this whole question of how do we be ready for national scale issues. I mean, this is a great illustration of one time when we didn't excel by any stretch of the imagination. So we're hoping to draw a lot from that goes beyond, preparation for new viruses.
Well, with that point, I mean, we know how to anticipate and get ready for catastrophic weather events. We know how we have to respond to a military threat or assault or conflict, even a terrorist event. We've got an infrastructure in place for that, and in response to 9/11, we created the Department of Homeland Security. I think the mystery is, we thought we had it all in place for responding to a pandemic, and it didn't happen. It didn't mobilize, and that's profoundly disappointing for a lot of us.
I'm looking forward to a time when we can get more insight into that and then shift things. I would say that it's when I get a chance to listen to people like the General Levy's of the world and others who are concerned with some of those things that we presumably have great knowledge of how to respond. They're also saying the world is different now and we aren't necessarily as ready. So I think they will be glad if we can extract something from this experience where they are encountering new kinds of threats and in different ways as well. One thing we wanted to talk about a little bit today, you do so much work with children, and in the whole broad COVID conversation so far, they've been kind of on the sidelines of that because so many of them don't symptomatically severe. But anyway, the note about your work with the COVID-19 children's vaccine, I'm just curious, what would you like the audience to understand about how that fits in all this?
Well, one of the things, it's not just the children's vaccine, it's a sort of a low cost vaccine for low and middle income countries. And, we've had great success here, with the 2 mRNA vaccines from Moderna and Pfizer. The problem is right now, the technology is still relatively new and we don't have the ability to scale up production. So those 2 vaccines will have an important role in North America, especially the United States and Europe. They're not going to filter to Africa, poor countries in Asia and Latin America. And unfortunately, a lot of the big vaccine developers have either dropped out or have been delayed. So, our usual workhorse companies around global vaccines, Merck and Company, Sanofi, GlaxoSmithKline, are really not in this to the level that we would have thought. It's more of the newer companies trying to promote their new technologies like Moderna and Pfizer, BioNTech, and AstraZeneca, which is not a vaccine company. So that's interesting. And the consequence of that is we don't have a lot out there for Africa, Asia, for the poor countries in Asia and Latin America. So what do we have? We have the Johnson & Johnson vaccine, I think, will be there for low and middle income countries when the adenovirus. The AstraZeneca vaccine will, but it doesn't look like it's going to protect against the South African variant. So if this starts accelerating through Africa, that's a problem. That's why we came in with a low-cost recombinant protein vaccine, kind of old school vaccine, the same type used to make the recombinant hepatitis B vaccine. It's been around for 40 years. We licensed it to a non-exclusive license to Biological E in Hyderabad, India. And, the Indian manufacturers are really interesting. They can scale up production of vaccines like few other companies can, and they almost work them like commodities. So Serum Institute of India makes most of the measles vaccines for Africa. Biological E is similar. They're scaling us up now to 1.3 billion doses for what we hope would be $1.50 a dose. So one of the lowest cost vaccines as well. And so we're hoping that will make a difference. We'd love to bring it into the U.S., but Operation Warp Speed is only negotiating with the pharma companies. So we haven't figured out a way around that yet.
We have to figure out how to get you the right audience for that. It seems like to me, I don't know if you caught the comments earlier, just from General Levy, but he spoke about the small e, focusing on efficiency, and a big E focusing on effectiveness. And sometimes, the right answer is somewhere in between. But we have to decide: are we striking the right balance between what, like, so I find it fascinating that you're working on a what you believe to be a very effective one that is also very efficient on cost.
Yeah, I mean, what happened was with with Operation Warp Speed and with a global entity called CEPI, Coalition for Epidemic Preparedness Innovation, there was a huge emphasis on the innovation part.
Right.
And I, look, I'm a scientist. I'm all for innovation. I sometimes think, though, we could have balanced it out a little bit better with some of the old school technologies. In other words, think of it like a portfolio. We have, because we don't know really what's going to work, have some of the, and I think it's, and no question, the mRNA technology is going to be game changing. And eventually, maybe over the next 5 years, maybe sooner, we'll figure out how to scale it better so we can make it for low and middle income countries. And then we'll figure also out how to keep it stable at room temperature so we don't have those onerous freezer requirements. I'm pretty optimistic that we'll come up with a way for doing that. But in the meantime, for this pandemic, it became a little too precious in terms of as a technology,
Yeah.
to make it easily scalable. And so we needed that balance.
I see what you mean. Well, one of the themes for today, and for kind of trying to find new models, is, and it's already been mentioned, is under this umbrella of collaborative work. And portfolios are a representation of that, in a way, where we say we're not just going to pick a winner and put all our money there. We're going to find a way to bring parallel things along and see. But I also know that in many cases, so sort of like the drug you have been working on, not getting into warp speed mentality or participation, this is akin to some of the problems our high-tech small companies have, trying to, join the party for larger, with larger scale companies for defense related things, as was discussed. And so a topic that's really on many of our minds is, how do we get across boundaries where this all for, really being unified in a purpose can help us cross the boundaries that where we normally compete, or normally just are siloed up and separate and don't know. I'm wondering, what you would say about some of those things, because I think they're very relevant to your work and getting the solutions out there.
Yeah, I mean, I think for instance, with the vaccine ecosystem, we all hear about the multinational companies, but I think the smaller mid-sized biotechs had a lot to offer, and even this group of very interesting vaccine manufacturers, developers that actually brand themselves the Developing Country Vaccine Manufacturers Network. They meet once a year, and India they're well represented by Indian companies in Indonesia. And the problem was they didn't have the upfront capital to move forward quickly. And often they will work with academic laboratories like us. So we partner with Biological E. Now we're in discussion with the Indonesians, how we get some of those upfront investments, because the problem is this. I think everybody on this call would say that COVID-19 is more of a public health threat. It became, right, it destroyed the global economy, at least for a while. And it became a security threat. It's highly destabilizing, and yet we still don't want to create that upfront investment to make it easy for multiple players to produce vaccines. And I think part of the answer is working through the G20, the group of 20 nations, because right now, when you look at who funds global health innovation, overwhelmingly it's the United States government. Second is the UK. Third is that country called the Bill and Melinda Gates Foundation. I think fourth is Germany, and then the bottom falls out. So we're not getting enough contribution from the other G20 countries. China needs to do more. Japan has started. They created this GHID fund, Global Health Innovation Technology Fund, but it's too small. Korea has done the same thing with a Right Fund, Research for Innovation, Global Health Technologies. But we need to create greater awareness. And then also, even outside the G20 countries, I mean, a country like Pakistan, for instance, which has the scientific sophistication to develop and stockpile nuclear weapons, and yet they've not invested in anything to develop vaccines. And so, trying to create that kind of awareness and responsibility, I think is really important.
Well, one of the great challenges for tech companies early on is to attract investment. And in this context, it just strikes me that, one of the reasons you can get millions upon millions of dollars put into a big pharma solution is because people already have the confidence that if it works, they then can get it into the market. They can handle that scale. And in other areas, one of the things that we're finding is that if we can build the story where investors can have confidence that should a little guy come up with something, we can actually complete the path and really show that there is a path. So I'm curious in this case, what you're talking about, if you took this council of, nation or companies that are building, low income country vaccines, do you think the issue is we don't understand the capability, or are they lacking the capability to kind of bring a solution to the world once they?
I think it's a great question. I think we just, we need innovation and sustainable financing for something that has poor market potential. So, for instance, if you notice, as I said, the big players are not in this. Merck, GSK, Sanofi. The companies that are developing the vaccines are, you could argue, and I don't, I can never know their true motivation, is, Moderna is not a vaccine company. BioNTech's not a vaccine company. I mean, they were able to get an enormous stimulus package from the federal government to accelerate their technology and also provide a glide path through the regulators. So in some ways, it was an economic stimulus plan for not the vaccine companies, and the result, was they made good vaccines. But the fact that, the big players were not really rushing into this, I think there was a lesson there for Merck and Company. Merck, did an amazing job back in 2015 2019, developing the Ebola vaccine, a project they started in 2015. That vaccine had 90% effectiveness. It basically stabilized the African continent in preventing a massive Ebola outbreak. But, I've talked to a couple of Merck scientists, and they've said, look, Peter, if we had to do it again, I'm not sure we would, because not only do we not have any guaranteed purchase of that vaccine, but we had to pull all of our best people from lucrative projects in order to make that happen. And so there is enormous capability there, but there's just not a sustainable financing plan to make vaccines that we need. So what do you do for something which is a global good, but people aren't willing to pay for it? And so I have a parade of young people that after I give a lecture to say, hey, Dr. Holtz, I want to go into global health just like you, and they think I'm going to explain to them how to study tropical infectious diseases. And they're often very disappointed when I tell them, please get an MBA, because there are scientific hurdles, but our big problem is we don't have innovation and sustainable financing. There is an answer out there. I'm pretty confident of it. I'm just not smart enough and don't have the background to know how to do that. That's why, when you gave me the opportunity to talk to this group, I said, yeah, because these are the
Well,
guys these are the guys we need to help us figure this thing out. You know?
I couldn't agree more. And I also want to tell you that I think the way you framed that problem is instructive in some things that we need to learn as well for other reasons. We have a couple minutes left in our slot here. So I just will say, thank you again, but also, do you have any final thoughts? I think you framed some things really well already, but I just send us off with whatever you'd most like us to hear and remember.
Well, I've devoted my life to developing vaccines for poverty-related diseases, and we're making progress. We have vaccines for schistosomiasis and hookworm and Chagas disease, and we took on a coronavirus vaccine program because it was orphaned 10 years ago because nobody cared about coronavirus vaccines. Now people care about it, but because we saw SARS, we saw MERS, we knew something like COVID was coming around the corner, and it did. And because of all that R&D we invested in, we knew that the spike protein was the soft target of the virus. We figured out how to deliver the spike protein. We knew virus neutralizing antibodies. So that 10 years of investment is the reason we have COVID vaccines now. But guess what? We're going to have COVID 26. We're going to have COVID 32. This is a new normal. And yet we still haven't put in place any kind of infrastructure to make that happen. And so that's going to be.
I'll take that as the thing to remember now, while the pain is still fresh, is that we got to fix the system, right? I mean, we just can't walk away and hope for the best. Thank you so much for your time. I think we're due to hand the mic back to David, but it's great to talk to you, and thank you for your contributions.
Thanks so much. Thanks so much for having me.
Rest of the time.
Thank you, Dr. Holtz.